sponsored by the Minnesota Gerontological Society and the University of Minnesota Center on Aging and MAGIC. So many people have expressed interest in our topic today. Our topic is on using yoga for managing chronic diseases in older adults. And the interest is very evident, as I've already received a question before the webinar even begun. My name is Pat Schomer. I am your moderator today for this webinar. I am with the University of Minnesota Center on Aging and the MAGIC program, as well as a member of the MGS board. MAGIC, if you are not familiar with the acronym, stands for the Minnesota Area Geriatric Education Center. These monthly webinars have become a hallmark of our two programs, and we want to continue to bring timely topics to you and to your organization. More details and information about upcoming webinars can be found on MGS's website at www.mngero.org. That's mngero.org. If you go to our MGS website, then to the webinar page, you'll find links to the information that will be discussed in today's webinar. Let me go over a few logistics before we start. Your conference audio is muted. If you have a question for the speaker, please feel free to type that question into the chat area at the bottom of your screen. If you have to leave the webinar early, just close your browser, hang up your phone. If you have other questions or concerns, please feel free to email us at MGS. After the webinar today, or at the very end of the webinar, you will be emailed an evaluation, or it will pop up on your screen. We are very interested in learning what you liked, what you didn't like, what you think we can do better, and any future topic ideas. Further information on continuing education credits will be available at the end of the webinar. There are a few groups at facilities that are participating. If each person wants a CEU certificate, the supervisor or person completing the survey after the webinar should list each staff person and email in the survey question about CEU certificates. The only way we can assure that each person who wants a CEU gets one is if their name and email appears in that question. I want to remind you that CEUs are free for members of MGS and $25 for non-members. We'll go over that information at the end of the webinar today. After today, our next webinar between MGS, MAGIC, and the Center on Aging is on December 9th, again at 12 noon. Our topic is Aging, the Good, the Bad, and the Ugly by Dr. Bob Kane. Today, Corjetta Chung is joining us, and we greatly appreciate all of the work that you've put into bringing this information on yoga to us. Corjetta is a PhD RN. She is a tenure-track assistant professor at the University of Minnesota School of Nursing. She has completed a postdoctoral fellowship funded by the Hartford Foundation and is an active member of the Gerontological Society of America and the Midwest Nursing Research Society. Her research focuses on the use of complementary therapies for health promotion and symptom management in older adults with chronic health conditions. Dr. Cheng has conducted a number of randomized controlled trials to examine the effects of yoga on knee osteoarthritis. We are pleased to welcome our presenter today, Corjetta Chung, professor in the School of Nursing at the University of Minnesota, speaking on the topic of using yoga for managing chronic disease in older adults. And so, Corjetta, I turn it over to you.
Thank you, Pat. Good afternoon, and thank you for all of you attending this webinar. My name is Corjetta Chung, and thank you for the nice introduction. I've been interested in aging research for over a decade, and I'm very delighted that I get to share with you today findings of a couple of my projects on the use of yoga for managing chronic diseases in older adults. I have no financial relationships to disclose, and I will not discuss off-label use and/or investigational use in my presentation. The objectives of my presentations are, at the end of this presentation, you'll be able to understand the safety and feasibility of using yoga for health management in older adults with chronic health conditions, and also to describe the current evidence on the effects of yoga on chronic diseases in older adults. Now, many of you perhaps already are yoga practitioner and practicing it regularly, and some of you may not know much about yoga. So let me begin this presentation by giving a general overview of yoga. So what is yoga? Yoga is a mind-body practice with an ancient history originally derived from India. It is more like a philosophy and tradition rather than a religion. The word yoga means union in Sanskrit, and yoga is divided into many branches. Hatha yoga, the physical practices of yoga, is commonly practiced in the U.S. as a form of exercise. Hatha yoga typically combines physical postures, breathing techniques, meditation, or relaxation. There are about 1,300 variations of yoga postures documented, and 84 of them are classic yoga poses. You probably have heard certain poses named such as tree pose, warrior's pose, downward dog. And the prevalence of yoga actually show a very significant increase between the year of 2002 and 2007. It was according to a national statistics report. It rised from 5.1% to 6.1%. And the question was whether they used yoga in the past 12 months. So perhaps the statistic will be different if it was a lifetime assessment. Another report was performed by a marketing survey in 2012 in California, reported that there was 8.7% of U.S. adults practice yoga. Now, whether it was a lifetime assessment or just past 12 months, that was not reported. So nonetheless, 8.7% of U.S. adults, that's 20.4 million people, practice yoga. And among them, 37.2% were adults older than the age of 65. Now, also the report says that people spend 10.3 million a year on yoga classes and products. That it probably explains why it seems every corner you turn, you see a yoga studio. And how popular yoga is, just try to Google it. If you put the word Google, I put the word yoga in Google, you will get over 52 million hits. So that is really a significant, very common, a common form of exercise. So this slide is just to show you how yoga is the top 10 common complementary therapies among adults in 2007, and also is one of the top 5 modalities that has the most significant increases between the year 2002 and 2007. So another national study was conducted to describe the characteristics of yoga users. And they found that majority of yoga users identify yoga as being very helpful for health maintenance. And they also found that people who have certain medical conditions are more likely to practice yoga. And most of these conditions are chronic in nature, such as the musculoskeletal condition, mental health problems, and asthma. So given the nature of this audience, I don't think I need to explain much about what's older adults. However, older adults with chronic health conditions, let me tell you more about it. About 80% of older adults have at least one chronic health condition. And chronic by definition means long-term, and the cure is rare, and it requires daily management for a long time. Now, older adults are the largest consumers of healthcare, especially medication use. And obviously there are certain medical therapy concerns such as polypharmacy and also prone to drug-related adverse effects due to the decrease in renal and liver functions and also increase in fat lean muscle ratios and decrease in serum protein levels. It doesn't take much for adverse effects to occur in older adults. and avoiding side effects from medication is one of the main reasons for seeking complementary therapies. Exercise is good for everyone, and it's particularly needed for older adults in order to maintain health and preserve function. And yet, exercise adoption is low in this population. And older adults, especially those with chronic musculoskeletal pain and disability, which is very prevalent among the older adults, they do not exercise regularly. And therefore, yoga, which is a mind-body intervention that uses a gentler approach, can potentially be a feasible and effective option for older adults with chronic health problems, not only for them to manage symptoms, but also for those who are not regularly exercise because of the nature of exercise. It's too hard, or they can't do it. Yoga might be a feasible option for them. So yoga is very active. I mean, it's very popular. And how popular it is, not just at a personal level, but there are organizations actually recommend using yoga. Several aging-related and health-related organizations have yoga on their webpage. The National Institute of Aging at the NIH has a special webpage that talks about older adults' use of yoga. And also the American Senior Fitness Association has also information on how to use yoga safely, and also what kind of effect yoga may have in older adults. The AARP also has a page on what yoga can do for you, and also a little video clip on real men can do yoga. And these are very, the public can easily access these websites. The Arthritis Foundation also has information on how to begin yoga, 10 tips to help you get started. The webpage includes specific different poses and what kind of effects it might have on you, and it might help improve how you manage arthritis symptoms. The American Heart Association also has a page on yoga moves to improve heart health. So as you see, there are organizations actually not just acknowledging it, some are even recommending people using it. So how much evidence do we have? Well, if you think it's that popular and it's been around for thousands of years and it's recommended by several well-established organizations, yoga must be safe and effective, right? Well, that's probably true to some people who believe in it and practice it regularly. However, the evidence-based practice has become the driving force in the healthcare fields in the past few years. In order to incorporate any treatments or interventions into mainstream practice, we need proofs and evidence from well-designed studies. A majority of yoga intervention research focusing on a number of these health conditions: musculoskeletal conditions, psychiatric conditions, cardiovascular, and respiratory conditions. And several meta-analyses also have been conducted to evaluate the effects on yoga, and among those, the result on low back pain drew very special attention. Recent practice guideline published jointly by the American College of Physicians and the American Pain Society suggests yoga as a therapeutic option for patients with low back pain. A number of systematic literature reviews and meta-analysis also indicate that yoga is a safe and effective intervention for chronic health problems. So in addition to low back pain, it also found that yoga is good for anxiety and depression, and also help improve quality of life in patients with cancer, reduce hypertension, and also improve immune response. However, these studies focus mostly on younger adults with wide age range, so results may not necessarily necessarily be transferable to the needs of older adults. Therefore, I, along with a couple of my colleagues, conduct a critical literature review on this very topic to examine the relevant studies on the efficacy and safety of yoga for older adults with chronic health conditions. And also we synthesize the findings to determine the evidence on whether the practice of yoga is safe and beneficial in older adults with chronic health problems. So we conduct literature review on all peer-reviewed articles from January 2000 to December 2013. And using keywords including yoga, older adults, seniors, elderly, and aged. And using different databases, including the Cochrane databases of systematic reviews, the Nursing Journal database and all, and also database of abstracts of reviews of effects, Medline, which is the medicine the journal database, and also PsycInfo, which is a behavioral sciences and mental health peer-reviewed journals database, and ProQuest, which is a digital dissertations database. So a total of 258 articles were identified. So after reviewing the titles and the abstracts, we excluded 151 because they were not eligible, they were not suitable for this review, and 72 of them were duplicates. So that left 35 full text articles reviewed for eligibility criteria. So we reviewed all these articles, 35 of them. And we had further excluded 20 of them because they did not meet the age criteria, and also one of them because there were no random group assignment. This particular review focusing on randomized control trial. So a total of 14 studies were reviewed. And among the 14 studies, there were actually only 13 randomized control trials. 2 of the studies reported from the same study, same trial. So this is a matrix that we created, and we categorized these 13 randomized control trials under author, the design, and total sample size, percentage of women, their mean age, the type of health condition, participants accrual, intervention and control group, and also the dropout rate and reason. As you see, the first 4 studies that I put here, they are from all over the place. South Australia, Taiwan, India, USA, and also the sample sizes varied from 14 to 250. And a variety of health conditions, and also a variety of yoga interventions. Just the 4 studies here, we have Hatha Yoga, which we talked about is the most commonly practiced in the U.S., and Silver Yoga, which was developed by the researcher specifically for older adults. And then we have the Integrated Yoga, which combined more meditation, lessons, chanting, and physical postures. And we have also the Iyengar Yoga that is use more props and more gentle than other type of yoga. And also we see the different dropout rates from 0 to 29%. Here's another 5 studies. And we have studies from Cuba, USA, India, and also different conditions including type 2 diabetes, kyphosis, overweight and obese with cancer, sleep problems, and stroke. And Hatha Yoga seems to be the common ones among these studies, and some did not identify what type of yoga they use, and they just said yoga. And also some did not report their dropout rates. Okay, this is the last 4 studies from Iran, UK, Turkey, and India. The sample size about the same, tend to be small, and we have conditions including depression, type 2 diabetes, osteoporosis, and laughter yoga. And again, 2 of the studies did not differentiate the type of yoga that they used. And also 2 of them did not report the dropout rates. So we have one study that has less than 1 dropout rate, and then the other one has 15. So the study, all these 13 randomized controlled trials include 1,078 participants with a mean age of 66.3 plus or minus 8.6 years, and 75% of them were female. A wide variety of chronic health conditions were included, and also the types of yoga interventions and doses were also varied across studies. And also the requirement of how many times a week they need to practice as a group, and also home practice requirement varies across studies as well. And the overall quality of these studies is moderate to high, and we use the Jadat scale, which is specifically designed for evaluating quality of randomized control studies. The majority of these studies also did not justify the sample size, and also they include small numbers of participants. So before I move on to the findings, Pat, are there any questions out there so far? Okay.
The question that stands is the one that came in prior to the webinar beginning, and that is asking about if there are certain contraindicated poses for certain conditions such as osteoporosis. So I suspect you may get to that information as you go along.
Okay, yes, I will. All right. So let me move on. So specifically, specific findings on diabetics. Fasting blood sugar in the yoga group and the exercise groups were significantly reduced by 29.48% and 27.43% respectively. And 3 studies were conducted on the use of yoga for diabetes. And the first 2 findings were found the same across all 3 studies, that it has positive effects on reducing blood sugar and also serum total cholesterol. And all of them use an exercise group as also a comparison group, and also control group, which is usual care. And these studies found that both exercise group and yoga group had positive finding, but as you see the numbers, yoga was superior than the conventional exercise groups. And also they found lipid peroxidation significantly reduced by 19.9% and 18.1% in both yoga and exercise groups respectively. Significant improvement were also seen in oxidative status in both groups. Superoxidate dismutase were increased 24.1% and 20.2% respectively. And catalase were increased 13.7% and 13.2% respectively in these enzymes to protect oxidative stress. There were no significant changes in diabetes-related quality of life and self-efficacy. Findings on stroke indicate that fear of falling decreased significantly and static balance increased significantly. There was significant improved in quality of life and balance self-efficacy, and changes in depression and anxiety, however, were not significant. And this particular study used usual care as a control group, so there was no another comparative group. They were just comparing yoga with usual care. Findings on COPD indicate that there was significant decrease in dyspnea-related distress in the yoga group, and increase in 6 minutes walk distance and self-reported physical performance compared to usual care control. Dyspnea means difficulty breathing, so yoga seems to be helpful for ease to breathe. No significant changes were found within or differences between the yoga and usual care groups in all psychological measures. And the control group in this particular study were usual care, and they were just giving pamphlets about the information on how to take care of COPD. Kyphosis. They found that participants in the yoga group had a 4.4 improvement in the flexi-curve kyphosis angle and a 5% improvement in kyphosis index. However, no significant improvement in kyphometer angle or quality of life. For osteoarthritis study, this is the study that has two reports, and one report on mostly the physical findings, the symptoms, and the other one report on quality of life. So I combined the two studies in this one report. They found that significant improvement were seen in both between and within group analysis. So there were three groups. There was a comparative group, exercise group, yoga group, plus control they use education. And they found that yoga improved resting pain, stiffness, state and trait anxiety scores, blood pressure and pulse, and quality of life only even at 2 weeks, and then the effects sustained at 3 months. So osteoporosis. They found that the levels of pain and household activities significantly improved in both yoga and exercise groups. Functional activity, one-leg stands, mobility, social activities, general health, and mental health were significantly improved only in the yoga group. Fatigue and overweight. For fatigue and quality of life, those who attended at least 24 yoga classes had significant improvements, and they also found reduced in waist circumference with no difference in weight change among participants in the yoga group compared with the control group. And for sleep, they found that yoga group significantly reduced in the time taken to fall asleep, so 10 minutes less, and also increased in the total number of hours sleeps, was an hour increase. And they also found that the feeling of being rested in the morning after 6 months after practicing yoga. For depression, the study found that there was a significant difference in depression scores by laughter yoga and exercise therapy group when compared to the control group. There was an increase in life satisfaction by laughter yoga group, show a significant difference in comparison to control group. For frailty, the study found that yoga group significantly reduced body fat percentage and reduced respiratory rate and increased right shoulder abduction. And yoga group had better low body flexibility, right shoulder flexion abduction than the waitlist control group at 12 weeks. There was a significant differences between the two groups in all physical fitness indicators at 24 weeks at the end of the program. Now, the study did not explain why only the right shoulder abduction, not the left, but that's what they found. And it could be also perhaps because most people are right side dominated. So the conclusion of these this literature review is that low quantity and a wide variability in yoga programs and outcome measures. And majority of these studies report yoga was safe and effective in improving physical symptoms associated with chronic health conditions in older adults. However, because of the small number, and it makes it kind of difficult to draw any conclusive, definite conclusions. and more research definitely and using vigorous methodology and reporting is warranted. Given that said, I personally contributed to this body of knowledge by conducting a couple of randomized control trials. My personal interest is in osteoarthritis because of its massiveness. Almost everyone, when you hit the age of 70 and 80, have some type of joint pain. And it is also very prevalent that it causes pain and disability. And because of the aging, the population is aging, so the prevalence is expected to continue to rise. And so not only the pain itself, but it also the effect of osteoarthritis on mobility. It causes activity limitations, so it has both physical and psychological effects. And because of reduce in mobility, so people with osteoarthritis are more likely to develop other lifestyle-related comorbidities. So you look at this slide, shows that how the bars gradually increase. So by 2030, 67 million people will be affected by arthritis, and also 25 million of them will have activity limitations. So osteoarthritis is the most prevalent chronic joint disorder that causes disability and pain in older adults. And because there is no cure, practice guidelines recognize that different self-care and exercise programs are essential elements for any OA treatments to help keep individuals with OA to remain active. However, there is limited scientific evidence to support the use of yoga as an effective option for OA. And when I received this postdoc fellowship, there were less than a handful of studies out there were studying the effect of yoga on osteoarthritis. And despite the lack of evidence, the Arthritis Foundation actually recommend yoga to be used as one of the fitness programs for managing arthritis. So I conduct a pilot study and to investigate the feasibility, safety, and acceptability of yoga for managing osteoarthritis in older women. I conduct a randomized control trial with 2 arms, immediate treatment group and waitlist control. And the purpose of that is that so I can compare the immediate treatment group with the control group, which the waitlist control group before the waitlist received their the intervention. So I have 2 groups to compare. And also after the waitlist control group received the treatment, I collect data from them and I combine the 2 data sets and make the sample size bigger. Data were collected at multiple time points at baseline before the program begins, 4 weeks halfway through the program, 8 weeks upon the completion of the program, and also at 3 months follow-up. So after 8 weeks, they were on their own, and we just sent them a survey at 3 months to ask them if they were still doing it, and also measure their the outcome variables. And all classes were taught by the same registered yoga teacher, who also happens to be a DPT, a doctor in physical therapy. The 8 weekly yoga intervention program was developed by a group of 5 registered/yoga teachers, a panel of 5. And after they designed the program and it was reviewed by 3 yoga masters, they also, 2 of them were also researchers to make sure that it's safe and it's applicable to this population. It was a weekly program, 1 hour per week, group session at a yoga center in St. Paul. And all participants were asked to also practice yoga at home on their own 4 additional days per week, half an hour. Every week they come, we'll give them handout to practice at home. A total of 36 participants were recruited and enrolled, and 4 groups of 9 participants completed the intervention classes. Actually, 2 people dropped out of 36, and 1 person hasn't even begun the intervention program. She was in the waitlist control group, and after she completed the control time, right at the beginning, before it was the waitlist control term to get their intervention, her schedule changed. Her daughter had a baby, so she had to help babysit, and also because her daughter got a new job, a full-time job. And the other participant dropped out after 4 weeks of intervention. Before she began the program, she already complained of severe pain, knee pain, but she was hoping that the yoga will help alleviate the pain. 4 weeks passed, and it really did not give her the result as she had hoped, and she decided to go and get a cortisone injection in her knee. And once she did that, she became disqualified to remain in the study, because we would no longer be able to measure the effect of yoga on symptoms. So outcome variable, we measured OA symptoms, including pain, stiffness, and function, using a specific tool called WOMAC, was developed by the University of Toronto, and it was well validated. Their physical function of the lower extremities, we measure them using a tool called the Short Physical Performance Battery, and that has 3 components. Repeated chair stands that will assess their knee strength, and they were asked to get up and down from a sitting position 5 times, and also a balance test, and also a walking test, 8-foot walk, and to measure their gaits. I also used a tool to measure their sleep quality using the Pittsburgh Sleep Quality Index, and also quality of life was measured by using the SF-12 tool and also the Cantrell ladder. The Cantrell ladder has 2 components. One is to have them evaluate the quality of life, the current quality of life, and a ladder from 1 to 10, 10 being that this has the highest level of quality, 1 being the lowest. And also ask them to predict in 5 years where would they see their life will be. And I include those information in the analysis. There was no adverse events reported during the intervention period or at home practice. The OA symptoms started to improve. Pain, stiffness, and function started to improve at 4 weeks of yoga and continue to improve at 8 weeks. Physical function were noted to improve at 8 weeks. And sleep quality and quality of life, however, did not improve at any time points. One of the reasons we found that is that these ladies who volunteered to be in an exercise trial, they all came in with fairly high self-reported quality of life. So therefore, there wasn't a whole lot of room for improvement. So ceiling effect might have contributed to the non-significant findings of the quality of life. We found that yoga is feasible and safe and is acceptable for managing knee osteoarthritis in older women. So after that study, the subsequent study was to compare yoga with aerobic and strengthening exercises on OA-related symptoms. So I conducted another study with 3 arms, a yoga group, aerobic strengthening exercise group, and also education attention control. So we have a yoga teacher who will teach the yoga group, and then aerobic and strengthening exercise teacher will teach the class, and it's a once a week, weekly class, and the education group, we give them handout at the beginning of the program once they found out that they've been assigned to the control group. So we gave them information gathered from the Arthritis Foundation on how to manage osteoarthritis. And also we called them once a week because the other two groups got together once a week, got face-to-face in the attention. And we thought that would be fair for the control group to also get some attention from us once a week as well. Data were collected also at multiple time points in the study. Baseline, 4 weeks, 8 weeks is also an 8 weeks program, and quarterly for 1 year. So we want to follow them for a long time. So 4 different time points during the follow-up period. So 8 weekly intervention classes, 45 minutes long per week of group session, and also they're asked to practice at home. Yoga, we ask them to practice at home every day, 4 times a week. So including the class, it will be 5 days a week, as recommended by multiple organizations. And for the aerobic strengthening classes, we ask them to do every other day, and preferably not consecutively. So 28 participants so far completed the intervention classes and are being followed up right now. Another 25 consented and began intervention classes 3 weeks ago. So I'm currently doing that study right now. So based on this experience, it makes me better understand why the criticism of why yoga studies have small sample size, because it is such a challenge to recruit and retain older adults to participate in an exercise trial. Community dwelling seniors equals to active seniors. They are not easy to locate. It's not like hospitalized patients or those who live in long-term care. They are there. Community dwellers, you kind of have to know where to meet them, and they are rarely just stationed in one place. And also in Minnesota, we have this special group of people called the snowbirds, and they are not around here in Minnesota when it's cold. So 5-6 months out of the year, they're not here. So even some of them are interested in your study, then they can't come until a certain time, or they won't be able to finish. And also the eligibility criteria. The nature of randomized control trial is that you want to gather people who share common interests and not common background, common characteristics, so you have this homogeneous sample that you can compare. However, then if you make it too tight, then it's not reflective of the population. So I ended up had to change my protocol 3 times just so that I can include more people and also more reflective of the population. I had to relax the age limits. It was at first 65 to 90, and I changed it to 60 to 100. And also the other criteria was about exercise. They cannot be already doing regular exercise. A lot of the community dwelling older adults, they are doing some kind of exercise. So I had to relax them. If they just go to class once a week, that's fine. They can still be included in the study. And also older adults, many of them have health issues. So that, like if they also have rheumatoid arthritis, then they are not eligible to be in the study. If they haven't controlled cardiac problems or blood pressure issues, then they cannot be in the study. The location of the classes also makes a difference. They need to be conveniently located, cannot be too far, more than 5 miles, then they get discouraged about driving. Also the weather, road condition. One of my groups who completed, they are in the follow-up period, they had their class in December, January, and I learned that I should never have any intervention classes during those months, especially last year, and the weather was pretty brutal. And so a few of them, almost half of them, could not come on various days, and so they did not get the full dose, which therefore affect the outcome of the study. However, the University of Minnesota has good reputation. I have a lot of participants who contact the study because they are affiliated with the study. They graduated from the university or are currently taking some kind of classes, and so they want to be supportive of the university. And also, I have actually quite a few people, over 100 people, who contact the study and are interested and want to be a part of it. It's just they were not eligible, or they were not available during class time, or they were not able to commit for 8 weeks due to various reasons. So, in conclusion, older adults' use of yoga remains under-researched. And the nature of yoga, there's so many of them, mismatch of research method are often the underlying causes for inconclusive findings. Because there are many different styles of yoga and yoga classes, therefore choosing the right type and class is crucial. Now, I want to address the question that was raised for are there any special poses that should avoid for people with osteoporosis. There always a risk when you start any exercise, so you just have to know your limit and also find the right class and find a teacher who is knowledgeable about different health conditions. As far as I know, there are not many particular poses that people with osteoporosis should avoid, but really depending on the level of osteoporosis that you have. If you have really advanced stage, then you really should not push yourself. You should just do more gentle yoga, and also when you feel resistant, you shouldn't push, you shouldn't force yourself, and otherwise it's pretty safe for people with osteoporosis. And I know, like people with hypertension, then you should avoid poses like that requires you to put your head down. And again, it's important to choose the right type of yoga, the right class, and the right teacher. And there's so many different yoga classes out there. There's Susie's yoga, Mary's yoga. And you just have to know, I'll tell the patients that they have to be careful when they choose yoga classes. It has to be more tailored to specific conditions or age group. And there are a number of senior yoga out there, or chair yoga, and for those people who are not, have low functional status. Again, the main, the advantage of yoga is that it's the teacher will work with individual, tailored to individuals' limitations, and there's some variations of the same pose that you can do. If you can't do it this way, you can do it sitting down or on a chair, or modify it, and just to fit individuals' function. So while many people, including older adults, are using yoga for health purposes, the lack of scientific consensus from inconclusive research findings often leave many healthcare providers unsure of whether to recommend yoga for health management. So I hope today's presentation doesn't give you confusion, but is to really show you that we have some preliminary evidence out there, but more research needs to be done. However, not sure if randomized control trial is the best method, given that yoga is mind-body. And if you talk to die-hard yoga practitioners, they do not really agree with treating yoga as just exercise. I mean, this is just really a piece of yoga that we are using, we are evaluating, and yoga is more than just exercise. Depending on your school of thoughts and where you stand, for me, we have to start somewhere. We have to be able to speak the language that healthcare providers are able to understand. And currently, randomized control trial is the gold standard. We'll use it and we'll test and see if yoga has any effects that can be objectively measured. And so that we can provide evidence for providers to be able to recommend that to their patients. But I hope there will be other methods out there that we'll be able to use and to really truly measure the effect of yoga on individuals and yeah, the true effects. So I'm open to questions if there are any.
There is not right now, but I see that Peggy is starting to type a question. Peggy, I only got the first couple words. If you want to finish your question, or if there's anyone else that wants to type in a question, we've got a few moments, and Corjana has graciously agreed to answer questions. Peggy writes, I work with an area agency on aging. Is there a chance yoga will ever become an evidence-based program endorsed by the AOA and the NCOA?
Well, I know in order for any organization to endorse it, they really want evidence. And by conducting research really help to help move that forward. And whether they will accept, you know, findings from one study, two studies, it really depends on the different organizations and also depending on the study. Obviously, larger trial with more sample will have, you know, the findings will be able to generalize more. And meta-analysis that offers the highest level of evidence, obviously, it's the best proof. But as you see after this presentation, that we don't really have a whole lot of randomized controlled trials out there focusing on measuring the effect of yoga in older adults. So we still have a lot more work that need to be done before we can get to that point. And however, I know, like, I guess from the healthcare provider's point, yes, we need evidence. But I know from the patient's point, because I also conduct focus groups on asking people the reasons why they choose to use alternative complementary therapies. They really don't care about evidence-based, the consumers I'm talking about. As long as it works, as long as it makes them feel good, they'll do it. So there's a little kind of a disconnect here. And but I agree, in order for us healthcare providers to recommend anything, we do need to be cautious. We need to really know the evidence, not just the efficacy, but also safety. And,
okay, we've got a couple more questions here. They're starting to pile in.
All right.
Bonnie is wondering if you have a list of providers that offer senior yoga or yoga for arthritis that you could provide for this group.
Yes, I do. Actually, not personally, but the yoga teacher who teaches in my study has a resource list. I can ask her for
okay.
it.
Why don't you?
She gave out to the participants, so I'll ask her for it.
Okay. We would be more than happy if you would get that to Tom. We will post that on the MGS website and send it out to those that have signed up for this webinar. Janet asks if you use incentives beyond the class itself to encourage attendance.
Yes. I guess nowadays that seems to be the rule of thumb, that you really can't expect people to commit to your study without giving them something as well. So classes are free, and the yoga group receive a yoga mat, and also every time when we collect data from them, they get a $10 gift certificates from Target. We can't give them too much. I mean, first of all, it's funding is limited, and second of all, you can't bribe them. You can't give them so much that it becomes coercive. And so the $10 seems to work for some people, but some people, even if it's free, they will. I mean, even if they don't get anything, they will still come. I mean, you just get the different types of participants.
Okay, we've got several more questions. Christine asked, do you think that doing yoga 2 times per week in class makes a greater difference? And she also wonders if the participants perform the home program consistently.
Very good question. Well, obviously the more perhaps will be better, especially if they come in, so then the teachers will be there to really work with them. However, transportation is an issue. And, you don't want to create extra burden that they have to drive there twice a week. So there was, I mean, based on my literature review, some study found positive findings, at a minimum of once a week. That's why I picked once a week. And also the other question about home practice. Now, my first study, I asked them to record it on their own on a log sheet, how many minutes they practice, how many days a week, and it's all based on self-report. Now, we all know that when it's self-report, you may tend to inflate the number a little bit. So then my current study, I asked them to, I give them each a camera that has video recording feature. So they were asked to record their home practice. Now some people love it, not love it. I mean, they don't mind it. They just use it as part of the commitment that they make to the study. But every group, I have a couple of them, seems to struggle with it. Not only with the technology itself, which button to push, even though they had the training session, they were giving handout. And some perhaps it's the privacy issue that they don't feel comfortable videotaping themselves, and they said it's a distraction. So I guess there's no best method to have them record the number of home practice that they do. You just kind of have to trust them.
Okay. Kathy asks if your literature scans, in doing your literature scans, if you found any research to Tai Chi and some of the other exercise groups in elders, how those compare with your results?
Oh, yeah. Tai Chi actually it's a bit ahead of yoga. Tai Chi had already a number of randomized controlled trials and a couple meta-analysis. So it's been heavily studied on the Tai Chi for osteoarthritis.
Okay. Peggy asks, or I guess she's making a statement that funding is usually directed towards evidence-based programs, and she agrees with you about the consumers. Let me go down. I've got several more questions. Mary asks if she's wondering if you could add a qualitative component to your study to explore the experience of people taking the yoga class. This might be a better way to capture an additional component of yoga, especially as many of the developmental theorists focus on ideas like transformation.
Wonderful, wonderful suggestion. But you know what? Great minds think alike. I did not mention that in my presentation because I didn't want to be too kind of sidetrack of this presentation. I actually, at the end of the 1-year follow-up, my current study, I will conduct a focus group interviewing them, their experience of using yoga and what helped them stick with it or what were the barriers. So like you said, including the qualitative component of this study.
Okay. Martha states that she agrees with your interest in the qualitative analysis benefits. She's also wondering if you would be willing to share more about your focus group results. And we've
Sure.
just got about 2 minutes yet.
The focus group, I conducted 2 focus groups. One was just focusing on the metro area to ask them their experience of living with arthritis and what type of complementary therapies they used and why they use it. And then another one I conducted based on the different geographical locations, so rural area, urban, and suburban. And findings were very interesting. And well, I know I only have a little over 1 minute left, but I will include the 2 citations, and both studies are published, so you can access to them. I don't know if that's something that whether I can send a PDF or if that's something that your organization will also help you locate the articles. But
Sure.
they both are published.
Great. Thank you so much, Corjana. Continuing education certificates are available for today's webinar from the Boards of Social Work and Nursing. They're free of charge for MGS, $25 for non-members. To obtain this benefit, please consider joining us at MGS. The application is available at mngero.org. That's mngero.org. An annual membership is only $75, and that's the cost of CEUs for 3 webinars. CEUs for the other 8+ webinars we host each year then will be free to you. We'd love to have your involvement at MGS. Watch for your evaluation survey. Filling this out is the step for you to receive your CEUs. For those that are in groups at facilities and participating, if each person wants a CEU certificate, the supervisor or person completing the survey after the webinar should list each staff person and their email in the survey question about CEU certificates. This is the only way we can assure that each person who wants a CEU will get one, and it's only if your name and email appears in that question. CEUs are free, remember, for members, $25 for non-members. Our next MGS webinar is December 9th at 12 noon on aging, the good, the bad, and the ugly by Dr. Bob Kane. Corjana, thank you so much for this interesting, lively discussion. We have several people saying thank you and asking about resources. There will be more resources on our website, and also the PowerPoint will be available. So thank you so much for joining us today, and we hope to see you again on December 9th. And Corjana, thank you on behalf of MGS, the Center on Aging and MAGIC at the University of Minnesota, for presenting this great webinar.
Thank you so much. It's my pleasure. Bye-bye.